The guest on this podcast episode has no disclosures to declare.
Social Determinants of Health in Cancer Care podcast. I'm Dr. Maysa Abu-Khalaf, Director of Breast Medical Oncology and Interim Chief of Cancer Services at the Sidney Kimmel Cancer Center at Jefferson Health. I'm joined today by Dr. Raez, Co-Director of the Memorial Cancer Institute at Florida Atlantic University and Florida Cancer Center of Excellence, and Whitney Renault, Patient Care Coordinator of Hematology and Oncology for North Florida and South Georgia Veteran Health Services. Thank you both for being a part of the conversation on data gathering.
It's a pleasure to be here.
Thank you for having me.
In this episode, we will discuss the challenges and barriers to collecting and documenting social determinants of health information for patients after a diagnosis of cancer. Our guests will share their experience in collecting social determinants of health information from patients and share who in their clinical team has been tasked to assist in obtaining this information. Last episode, we discussed data gathering from a patient's perspective, but we'd love to know why you both believe it's important to address social determinants of health and social needs when providing care for your cancer patients. Dr. Raez, would you like to just give us your thoughts on the importance of social determinants of health?
Yes, thank you. I am a medical oncologist. I'm a director of the Cancer Center here at Memorial in South Florida. It's a public healthcare system. I practice lung cancer, and as much as the social determinants of health topic is a topic that many medical oncologists believe is not ours, that is in the realm of the social worker or somebody else, there's no way to avoid that, because when you are providing the best target therapy of the world or the best immunotherapy of the world and the patient has insurance and you see that the outcomes are not the outcomes that you see in the clinical trials, you see that there is something else other than the biology that has an influence. That is why I consider the social determinants of health very important. In our own cancer center, we have several publications about target therapy, immunotherapy in Black patients or Hispanic patients that clearly show inferior outcomes despite the fact that they are getting the same drugs, the same doctors, the same care that we provide. That's why we consider in our healthcare system, as I said, Memorial Healthcare System, that very important topic that we have been trying to address for the last years.
Thank you so much. Whitney, would you like to add to this?
Absolutely. It's exactly. It indirectly affects all the outcomes or overall disease survival. If they can't get to the treatments, if they don't eat well during the treatments, if they don't have support during the treatments, it's going to negatively impact all of the outcomes. We do a great job in being able to pay for the drugs and, have great regimens. But if we can't get them to the drugs and the regimens and keep them coming, they're going to have, overall poor disease survival rates.
Absolutely. Thank you for that. Well, let's touch on the physician and clinician perspective. Dr. Raez, there has been a lot of interest in evaluating the impact of SDOH and patient social needs on cancer care delivery. Can you tell our listeners how you ask your patients about SDOH and their social needs? And does it happen during the clinic visit or, at a later time point?
To collecting the data of SDOH is the first step, because if you don't have an idea what is the impact of this. So that is why in our healthcare system, we are 2,000 doctors. We have created a dashboard of SDOH, social determinants of health, that basically we collect 13 of them, from social connections, tobacco use, depression, transportation, physical activity, etc. So this is a dashboard that is embedded in the EMR. So when the physician opens the EMR, if he has in the left side the vital signs, the dashboard of SDOH is in the right side with the medications, allergies, everything. So in that way, the physician cannot really ignore because it's part of his dashboard. So we figured out this working with Epic systems. Epic is one of the most popular EMRs in the United States, and it has the capability to do that. So we were working at the level of the healthcare system, not only for cancer, but for everything else. So now that we have these 13 SDOH, what we do is we are trying to flag a green or red, depending on what deficiency the patient has. No, if the patient has food insecurity, there is a red. If the patient has transportation, it's a green. So the physician can easily see if there is any red in the SDOH dashboard that can bring awareness about there is something wrong that needs to be addressed. And as we said before, I cannot expect that the patient will have a great outcome if I'm looking at a bunch of reds in the SDOH dashboard, despite the fact that I have the best chemos of the world in the left side.
And are you, as a physician, collecting this information during the clinic visit, or is there someone in your office that does that before they go into the clinic space to see you?
The dashboard, we already have the template of the dashboard, and then it's being populated by the social workers. You know, when you get a new patient, you come as a new patient in the cancer center, you interview the social worker, the nutritionist, the multidisciplinary team, and then we start to populate the dashboard. But as you understand, also collecting data one time is not enough. You know, the necessities can change. The patient may have transportation 1 year, next year, no. So once that the dashboard is created and kept by the social workers, the medical assistants in each visit ask briefly the patient if something has changed. The same when they change aid, you know, any of your medication has changed and the medical assistant has to fix if you have a new drug or no. The medical assistant keeps track of if the dashboard is updated or outdated.
Okay, wonderful. So it's continuity of care. It's not something that you just would do one time point. Every time they come in, the MA makes sure that it's updated, and you as a physician during the clinic visit will address any of the social needs that are identified or flagged to you.
Yeah, or if I cannot address them, because, you know, some of them are out of my expertise. For example, maybe the patient lost insurance. You know, now it's January 2nd and the patient lost insurance. But at least if I see that red flag, I refer the patient to the social worker immediately, because now we need to fix the insurance. The patient just lost the insurance or something like that. You cannot pretend to ask the doctors to fix these things by themselves, because the doctors are really very reticent, very negative about doing more clicks, you know. That's why when you present this to the doctors, the first reaction is everybody goes to the back, you know, like, oh my God, they're giving me more work. But it doesn't have to be like that. That's why we work as a team. We want you, at least at the minimum that the doctor has to do is notify the social worker, send a couple of clicks in the EMR, so we know that this needs to be addressed. We are not asking the doctors to fix things, you know, because otherwise the doctors get against this because they think it's more work for me in the less time and I don't get paid anything extra and it's not my problem. It's not like that. It's the same thing when you see that the blood pressure is high and you notify the nurse to give a pill, but now the SDOH has red flags and I will notify the social worker to please fix this, or the nutritionist or somebody else in the cancer center that can address this.
And I think that's very important because this comes up a lot. How much work is it? Can you really fit it in during a clinic visit? And the way that you've outlined this, it's a team of clinicians and staff that need to address this collectively and longitudinally. It's not a one-time point where you address it and you move on. Whitney, can you tell us, since your work has been with veterans, are there templates or guidelines that you found useful when asking patients about SDOH and social risks?
Great question. Thank you. And that sounds like, again, one of the reasons my job exists is to help physicians such as yourself be able to keep determining along the continuum of care what's going on with the vet and if they, are having changes. We use the NCCN distress thermometer and problem list, and the nurses actually in our infusion are seeing every single patient and assessing them up front. And then if they score higher than a 4, they're being sent to the social worker to be able to assess for needs, support. And then we actually are creating a consult to kind of flush out of that assessment into also mental health providers, depending on what, as Dr. Raez was saying, where the needs are. We might have consults to both social worker and the mental health team. I also do stem cell transplant, so we do a very thorough assessment of what they're needing, if they have good social support, economic ability to go through the transplant process, as well as emotional or educational understanding of what they're facing. And I'd like to see us be able to do an assessment like that for each individual, but I very much agree, instituting it along the continuum of care is needed. We need to do better at that for sure.
Wonderful. Thank you. And my next question is, obviously there's a team of clinicians and that might change depending on the practice and the patients that we serve. But do you find when you're trying to discuss social needs with patients, Dr. Raez, do you feel that they are comfortable addressing these questions with you, for instance, as their treating physician? Or do you find that they're more likely to talk to the care coordinator or the social worker about these topics? They're sensitive to some patients.
In general, no. As I said, for me, it's more to educate the doctors to be more open to talk about these things because, I feel it's part of our responsibility too. But certainly we don't have the expertise of the social workers, for example, if there is issues with insurance and we don't know if the insurance covers the treatment or no, things like that. Or for example, if my patient has transportation issues, I know that there are a lot of transportation options and NGOs, but I don't know which ones are. I know, for example, that at one point there were some Uber rides for free, but our social workers are the one that keeps track of the resources available, and that may help. And the other thing that we did also is we have a link for resources because nobody really has in their memory all of the resources available, and certainly we don't want to miss a potential resource. We have a link to a database that the social workers keep all the resources available that they have been able to collect in the area. That there is a grocery store that provides food for veterans or something. In that way, all of us can always check if we have some interest in to participate in the process to help the patient, how to help the patient, because it's important also to have an updated database of resources that we can be useful, because a lot of times we don't help the patients, not because there are no resources, it's because we didn't know that. For example, about these Uber or Lyft rides, I didn't know about that until one patient told me, hey, by the way, if I don't have transportation, send your patients with these resources. So it's been very important to be aware of the resources that we have.
And I think you touch a very important point, is a lot of it is as clinicians and providers, when we see our patients, we need education as well about the resources that are available in the healthcare network and the community, so that when these questions or social needs come up during a clinic visit, that we know that we can reassure them, that we'll link them with a social worker, with a care coordinator that can help them. It's often the providers are not always up to date with this information. So part of the process would be providing some educational information and updates about the resources so that they can discuss these as well with their patients when they're referring them to social work or care coordination, or a navigator as well can help with that process. So Whitney, how about you? Do you face challenges making connections with patients and getting them their resources during the VA system?
Yeah, it's interesting. I had almost the exact same scenario that Dr. Raez was speaking of with the Uber. Yeah, I was not aware of one of the resources that we had, and that there was an Uber program. And so, again, I second that as far as like just making everyone aware of it. We have 15 fellows, so I am constantly educating them on all the resources, and they cycle through. So, having those updated all the time is definitely a challenge. I think whether it's within a veteran system or not, large systems, just inevitably your resources are going to change continuously. So having somebody update that. I would say the thing unique to maybe the veteran population that I've found, because I've worked in the private sector and the academic sector, and now I'm in that with veterans, is they have, especially at the beginning of the visits and when they first meet with the providers, and even the social workers shared with me, when they're not familiar with the team, they have a bit of a generational and institutional kind of stigma of not wanting to present as weak. I think it's kind of unique to the veteran population. So myself and the other care coordinators, I feel, kind of play a pivotal role because we develop the relationship with them. We're on the phone with them all the time. We're meeting with them in the clinic. So they begin to trust us. And so sometimes that will come out. Again, I think that's a huge part of why reassessing across the continuum is so important, because, they'll walk into their first visit feeling pretty strong. We're going to beat this. I'm going to do this treatment. And then for all 3 months down the road, their family has left. They don't have a ride. They have nowhere to live. They're out of food or money. And, they're not going to share that with just anyone, but they will, once they begin to trust you. And, I feel like that's a huge part of my role as a care coordinator.
Thank you. I think that's very important that you point out that those social needs also change, right? Someone can start out with and they have the support, and then halfway in between something happens. And if we don't ask again, patients may not feel that's something to address with their physician or a provider on the clinical setting. So Dr. Raez, it looks like you have a good setup that across the health system that you work in, through Epic, and you have a platform. So what would your advice be, or what tips can you provide to clinicians in other practices where they may not have that, on how to start to incorporate addressing social determinants of health and social needs during the clinical flow and the clinical process? Do you all start it all at once or incrementally?
No, I think they can go through the same process. Doesn't matter if you don't have this Epic EMR. We don't want to advertise Epic. There are other EMRs in the United States. But as long as we start this conversation, if you don't know what is the data, you don't know how you're going to fix something that you don't know. So the minimum is to start to collect the data. And now it's not only enough to collect the data. For example, we are not happy only collecting the data and updating the data. Now we really want to show that collecting this data makes a difference in the outcome of the patients 3 or 4 years from now. That is the next step. But also we have to recognize that Whitney and myself, we work for $3, $4, $5 billion corporations. So we have the resources to do this, but 80% of the cancer patients are treated in the community. So we really need help from the government. I hope that the ASCO and other institutions keep pushing. For example, we already have from Medicare the C codes. The social determinants of health have the C as and zebra codes that we already exist. But for example, we don't get reimbursed for that. So maybe I have my lung cancer patient that has food insecurity, transportation, and I put today the C codes. Medicare pats me in the back, but doesn't make a difference. I'm only reporting. But maybe one day they have to recognize that the institutions are investing time and effort to collect the C codes and to document the C codes and even have interventions. So hopefully they can maybe give reimbursement for this. Smaller cancer centers, smaller practices can get more resources as we have, so we can implement this type of dashboards and programs. Because, I'm happy what we're doing, but I also understand that we need to do something that makes a difference for most of the patients, not only for patients from academic centers or large corporations like us. That's why I think it's important also from the legislature and the government to give us a hand. We need more resources to address the social determinants of health. And as I said, not necessarily is to hire more social workers, but the government already, for example, have C codes. If maybe one day we can get reimbursed in the C codes, the doctors will be more eager to intervene. Because remember, we get paid by what we document, what we bill, and with the coding. So that's why I think that's also important.
Thank you. This brings up a point where often we're all looking for the reimbursement. We're all looking for the data to support that this, in fact, affects outcome. But the problem is if we don't go through the process right now of collecting the data and following, as you said, for a few years upfront, it's hard to ever get to the point where we know for a fact that our interventions have an impact. My thought is always is that we go in parallel and we do what we have to do today and look forward to more data in the future as we collect this. The other point is it's not just, as you said, collecting data, right? So Whitney, what does success look like for you when you're trying to address a patient's social needs? And are there limitations sometimes that where you collect this information and you may not have direct access to the resources that the patient needs to address these issues?
Absolutely. I think you hit the nail on the head. Yes, I can collect the data and know what they're needing, but unless I have a resource and a program to guide them towards to be able to support them with that, then if anything, it causes a little bit of burnout, I would say, on nursing in particular, because you're a little stressed that you're not able to provide services to them. So if you're able to consistently, we could have a consistency of process and screening all of them and then identify the needs and have identified those commonalities of needs, at least you would be able to have some common programs like the ride sharing program, like we were speaking about with Uber, and certain resources that are common within those patient populations. Then we could identify that and have funding towards those types of programs. I think that would be the ultimate goal.
Thank you. So do you both have any final thoughts you'd like to leave our listeners with?
I'm very happy to participate in this podcast. I think it's very important that all of us start to collect the data as a step one and to make everybody aware that this is a real issue, that there is an impact in the survival of the patients. And this is something that needs to be addressed, and that the outcomes are not going to be the same for most of the patients, because most of the patients in the community, unless we address the SDOH in every patient.
I would kind of just second that. And I would say, my profession basically, its inception was because of social determinants of health, because of populations needing navigation. And so I kind of owe my entire profession to being able to be that support throughout that continuum. So I just think with more discussions like we're having, hopefully that brings attention to the importance of it. And like Dr. Raez said, collecting the data so that we are able to provide that and have that message sent forward to be able to get more resources and identify those resources, I think will just cause better patient outcomes.
Well, thank you both, Whitney and Dr. Raez, for joining us for this episode of ASCO's Social Determinants of Health and Cancer Care podcast. And thank you for all of the wonderful work that you do for the patients and for helping us with this process.
Thanks for having us.
Thank you for having me.
And a thanks to our listeners for being a part of this conversation on data gathering. Please join us for the next episode where we talk to a panel on the importance of community organizations, capacity, and infrastructure. To keep up with the latest from Social Determinants of Health and Cancer Care podcast, please click subscribe so you never miss an episode. And let us know what you think about the series by leaving a review. Visit asco.org/equity for the latest resources, research, and more on equity, diversity, and inclusion in oncology.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.